everybody. This is Carrie Myton, and I'm here with Tiaan Bennett. Hi, Tiaan.
Hey, everyone. Hey.
Thanks so much for joining us. We're going to try something a little new, a little different, and we're going to see how we go on the flow of content. Up until now, a lot of our content, for most of you who've seen us, seems to go for like an hour and a half, 45 minutes to an hour and a half. So we're going to try and do little shorts, pack-ins with really great content you can listen to while you're driving. You can put comments down below to ask questions and really start engaging in more meaningful weekly conversations about things that are really important to you. So today we're going to kick off with endometriosis. So there's been a lot of information that has come since we did our endometriosis webinar a couple of years ago. So Tiaan, first of all, we're going to just assume everybody here knows who we are. Okay, if you don't know who we are, you can go through our channel. You can listen to a lot of our other bits and pieces. We've got lots of webinars, lots of articles. We're the naturopathyclinic.com. Okay, so Tiaan, let's just jump in. So endometriosis. Okay, so up until now, I'm assuming everybody here kind of knows the conventional, like what is endometriosis, but how do you find we actually are treating endometriosis, and how do we actually look at endometriosis in the clinic versus conventional? Don't go too much into the deeper conventional, but how are we actually treating it, and how are we helping women with it?
We need to do a very triple-pronged approach with endometriosis. It's very much as a lot of us know, it's very much educated as a female reproductive hormone condition, but the emerging research is that while the estrogen, it's educated that it's an estrogen-driven condition, and while the estrogen is naturally much higher in endometriosis, the causation really stems from a dysfunction of the immune system, not recognizing that there's endometrial tissue that has escaped the uterus and depositing outside the uterus. It is hypothesized, some professors do hypothesize that every menstruating woman does have retrograde bleeding, and that endometrial tissue does escape the uterus and deposit outside the uterus. But we have a really good immune system that recognizes that is happening, and it mops it up. There's also a really large and key role that the gut and or vaginal microbiome plays in that inflammatory response with endometriosis. Now, how estrogen comes to play in this condition, because endometrial patients do have what most people refer to as estrogen dominance, is because in our endometrial tissue, in every female reproductive system, the lining of the endometrial tissue, it produces an enzyme called aromatase. And that enzyme is responsible for converting testosterone to estrogen. However, when we have endometriosis, we have so much more endometrial tissue. So because we have more endometrial tissue, we have more aromatase. So there's more conversion of that testosterone converting to estrogen. And so that's why it is an estrogen driven, or it is educated that it is an estrogen driven condition. And that's why women with endometriosis, they get a lot of pain, clotting, breast tenderness, mood changes, PMS, fluid retention, typically, potentially even weight gain as well in those endometriosis patients with the estrogen dominance picture. So from treating it in our clinic, we really need to go in with, yes, we do need to detoxify the estrogen, which is how we were taught at university, but we can't just detoxify the estrogen, because we need to understand where the causation is coming from. So we need to support the immune system. In other countries, such as the UK, it is classified as an autoimmune condition. It's not classified as an autoimmune condition in Australia because it doesn't tick all the boxes. However, in some respects, it very much behaves like an autoimmune condition. So we need to modulate, treat the immune system, support gut health and the microbiome, and also down the line is the detoxification of estrogen as well. So we need to go in with the immune system, the gut, and the hormones in our treatment. And that's why our patients get really good results.
Yeah, I think that's exactly what I was going to say. I think that's why our patients get really good results. There's a few really interesting statistics, and anybody who's here with us today, a big part of what we do is we read a lot of scientific papers. And in December of 2021, there was a medical textbook called The Immunology of Estrogen. Not estrogen. We wrote one later about the immunology of estrogen, but the immunology of endometriosis. And a lot of this further has shown what we've been doing in the clinic is actually how to actually treat endometriosis. And in that textbook, it was one of the first sort of pieces of literature or medical material that actually has said that endometriosis is actually, it's now sort of in the hypothesis stage, I guess in America, in the United States and in Australia, that it's a autoimmune condition. I didn't realize it was considered one in the UK. That's pretty awesome. So a couple of things, I'll give you a couple sort of questions that have come through around endometriosis, and then I'm hoping we can kind of show people what we're seeing as it pertains, because today's really about showing people what we're finding, and then also showing how we're actually treating it. So today I had someone who came to us who asked a question specifically about endometriosis. They've been seeing another practitioner for the last 6 months, and she's been doing a lot of gut work, and it was an acne specialist who she went to go see because she's had cystic acne. She's been on Roaccutane for the last 5 years, and basically it's like it helped get the acne gone, but like she's now she's now gone from having endometriosis to now she's getting scans to see if she also has adenomyosis. Okay, so a lot of things we hear from a lot of different people. That's why I'm bringing this question up. But she's not getting better. She's done a lot of gut work, lots of she's on supplements for her gut microbiome, and she did a short round of bioidentical progesterone, but not a lot of from her supplement ranges. She wasn't taking anything for her hormones, and she wasn't taking anything for her immune system. So why do you keep pressing? Because we talk a lot about the gut bacteria side of endometriosis. Why do you think you have to address the hormone side too, in addition to the gut side, in addition to the immune side? If she's not getting better, she's been doing this for 6 months. Why is she not getting better through the gut work?
Yeah. Well, it depends how good her gut protocol was. Something that we do need to treat without using too much jargon in gut health is something called beta-glucuronidase. It's an enzyme produced from lipopolysaccharide bacteria in the gut. And often we see patients who have done gut cleanses with other practitioners or, online programs and things like that, and it hasn't quite targeted some of that bacteria. It can be quite difficult to target that bacteria. So if certain bacteria is still producing beta-glucuronidase, that's going to affect the liver and prevent with the detoxification of estrogen. So there might be great other improvements with gut health, but if that isn't addressed, and if we're not able to detoxify the estrogen, then we might not get any major improvements in the pain or the symptoms associated with endometriosis. So the gut needs to be treated properly, and I've seen many times it's just not been treated properly, and I mean that with a lot of respect. The immune system needs to be addressed, and not just things that boost the immune system. We need to modulate the immune system, because it can, we don't want the immune system to be too overactive. We need to modulate the immune system. And then we need to make sure that the estrogen is detoxifying properly through the liver health and through, like I just said, making sure that that beta-glucuronidase is not too high.
Another thing that statistically has been spoken, I wouldn't say it's actually I can't find enough statistical evidence, but through the clinic, just looking at our stats and our numbers and our research, and when we do actually test, a lot of people have the MTHFR genetic mutation. So this is a hot debate. Anybody in the clinic knows I push them on this. Is it genetic, or is it the genetic mutation, or is it
totally?
What do you think? How many women do actually have this? MTHFR, and they're not actually able to absorb things properly, and that's led to the inability to get the full outcome and benefit of the treatment because they aren't actually getting the right type of micronutrients.
Like the genetic treatment. Yeah, we need to work upstream at the cellular level as well, at that genetic level as well. Endometriosis, it's so much easier to get a diagnosis, and there's so much more education and conversations around endometriosis. I spoke to someone the other day who's in her 70s, and she said that she definitely had endometriosis growing up.
Wow.
And she would go to her doctor, and her doctor just turned around and said, it's just part of being a woman. You're going to get period pain. And she now believes it was endometriosis. And when I speak to patients who have endometriosis, I ask them about their mothers or their grandmothers or their sisters. They often might not say, you know, my mum had endometriosis as well. Well, often they do. But yes, my mum had period issues as well. It's far more commonly diagnosed now, and it's more recognised. Yeah, the genetic, there is a very strong genetic composition to it. And that famous saying of your genes load the gun and your environment pulls the trigger. So you are more genetically susceptible to it if there is a family genetic factor, but it's also about your environment as well.
Yeah, and I'm gonna pull some of that. Let's quickly show. We're going to kind of bounce around. Again, we're trying to do something that we typically take an hour and a half to do. We're trying to fit this all into 20 minutes for the purpose of being able to punch out really fast content fast, like good content quick. So I just wanted to put something up that I think is really helpful for a lot of people. There's quite a few slides here, so y'all bear with me for a second as I kind of click through them. But this is one of the things that a lot of people find a lot of benefit in is actually, just let me know when you can see it on your side, Tiaan, because it's
I can see
not
it.
running online. It should be a picture of the actual of the actual
the actual gut test. Yeah, I can see the gut test.
This is a test that we've done. We used to do tons and tons and tons of genetic testing, not genetic testing, tons of gastrointestinal bacteria types of tests. And we've just seen so many that are similar that it can be a very expensive test. So for patients who need to invest more money in repair versus investing lots of money in testing, we're a good clinic to go to because we can identify the commensal bacteria. But just to give some context, I wanted to pull up this. There's two separate pages here, so I can flick to and from. But one of the things I wanted to bring up is why is it important to look at the bacterial element of things? Like, why is it important for people to care about the bacteria?
So first of all, with a lot of that bacteria there, the bacillus, the enterococcus, the pseudomonas, the Klebsiella, actually the Klebsiella is an autoimmune, is a very well-researched bacteria in the gut that is associated with the immune system and autoimmune conditions. The other bacteria at the top of this page are, without going too much into it, because we don't have an hour and a half like we generally do, they are quite pro-inflammatory. But the first thing I see in this test is the question mark around small intestinal bacteria overgrowth. While this test doesn't diagnose small intestinal bacteria overgrowth, statistically, endometriosis patients have 80% of endometriosis patients have something called SIBO, or small intestinal bacteria overgrowth. In our clinic, I would say that it's probably much higher. It's probably around the 90 to 100% mark. And key bacteria that is associated with small intestinal bacteria overgrowth are these ones: the bacillus, the enterococcus, the pseudomonas, the streptococcus. And that is a very pro-inflammatory condition. It is associated with a lot of gas, bloating, nausea. Yep, sorry.
Yeah, one thing I always kind of bring up every time we do this is you can start to see the immune element come in whenever you see this streptococcus one, which is 2 down from the line in the center. And streptococcus, a lot of endometriosis patients have had glandular fever. I'm going to skip to the next page too, so we can show both sides. But basically, a lot of people have had glandular fever, tonsils taken out, adenoids removed. There's usually something that happened. It's close to like 90% of the patients who've had something massive happen to their immune system, either as in childhood before the age of 10, or they got really bad glandular fever when they were in their 15 to sort of 25-ish zone. And a lot of patients there's definite dysbiosis and problems in the gut. This particular patient, Lauren, she's this story that if we get a second, we'll kind of go through her story. I'm not sure we'll have time today, but you can see like what were some key elements of this presentation from this particular that we have here as an example.
Well, first of all, she's got Helicobacter pylori, which is a bacteria in the stomach, and essentially the salivary glands in the mouth and the stomach is really our first line of defense for protecting the bacteria in our gut. And if we do have overgrowth in our stomach, and if we are deficient of those stomach acids and enzymes, it does create a really good haven for opportunistic bacteria to grow. So Helicobacter is further up in the digestive tract. And the fact that this is present indicates that it needs to be treated. 50% of the population do at some point in their lives have some level of Helicobacter pylori, but what we really need to look at is why this has come about in the first place. So we need to look at the stomach acid and the digestive enzymes. And she did really, really well on supporting those two factors, and that supports downstream at the prevention of the overgrowth of opportunistic bacteria.
Yeah, a couple of other sort of questions. When you look at, I'm going to kind of come off the slides for a second, and we're going to just talk again. One of the major conventional treatments for endometriosis is basically going into a laparoscopy. Okay.
Yeah.
So with the laparoscopy, like, when's the best time for us to get involved? And then like when you look back at the aromatase and the fact that it's increasing the estrogen, how does this all kind of come together? Like the bacterial part, why is it that the laparoscopies are actually working? And how does that change in the amount of tissue after it gets scraped affect the immune system and affect the menstrual cycle? Like, why does that actually work?
It does work, but it only works momentarily. I mean, we had a patient who has had 17 laparoscopies, and after each laparoscopy, she was so much better, but the causation was never treated, as in the immune system and the gut, and the endometrial tissue just kept on growing back, and she had 17. It's really common, and that's excessive, that's extreme, but it is common for women to have 2, 3, 4 laparoscopies. It does work, but it only works because it's literally taking out the excess endometrial inflamed tissue, and because it's taking that out, it's taking out that aromatase enzyme. And that aromatase enzyme is converting the testosterone to the estrogen, which is causing all those symptoms and the pain and everything. And that's why it works. Where we can complement that really well is, say a client does have a laparoscopy, we can then jump in. We've had many patients who have had many laparoscopies. And they've just had a laparoscopy, they've come to us and they've never had one since, because we've fixed the immune system and we've fixed the gut and we've fixed those underlying driving causes, and it's not come back. So I'm not against laparoscopies. When it's needed, it's not a bad thing. It is invasive, but it's only taking out that excess endometrial tissue, but it's not going to fix the causation. It will very much likely come back over 6 to 12 months. It usually gives like a momentary 3-month relief.
Yeah, so it's really addressing like the hormonal response when the period comes, because there's not as much tissue. But if you don't, just so I understand it, if you don't address the underlying problems, it's just a matter of time before the tissue grows back.
Exactly. Yeah. Yeah.
Yeah.
So often
So
women
when,
do it when they're trying to, sorry, well, often
go
women
ahead.
do it when they're, A, the pain is just unbearable, and also when they're trying to fall pregnant. Because if you do have that excess endometrial tissue, it can disrupt falling pregnant. So that's often when it happens, when they have laparoscopies. Yeah.
Okay. Okay. So when would you say like would be the best time to do something about it? Should they go and get a surgery? Should they, like this lady that submitted the question today, she
Yeah.
doesn't, she had a scan, you know, and she hasn't had a surgery. She doesn't really want to do surgery. Like,
Mm.
should someone do surgery first? Like, what, if you could wave a magic wand, when would be the right time? When should someone actually do something about it?
Mm. I'm always of the belief and try to go in with the direction of supporting the client's decision. We've had so many, but Lauren being one of them, crippled with pain, and 3 menstrual cycles later, she did not have a laparoscopy, but she was so much better. So we are getting results without laparoscopies. Absolutely, totally. The only time I would tell a client, yes, go and get a laparoscopy is when they want to fall pregnant. That's the only time when I would say, just go and do it. We'll still work together. We'll support we'll prevent it from coming back, and we'll support with the fertility side of things. But if it's not to fall pregnant, I would say just give us 3 months or 6 months, because there's so much that we can do. But we certainly also have had clients who have been in so much pain, they have had the laparoscopy booked and they've done it, and then they've come to us and we've worked with them and it's never come back.
And there's a big part, just so everybody knows, I like to be really honest with people. You are going to have to probably make some dietary changes. So, like, if you're, whether you work with us or you work with somebody else, the reality is there's typically a dietary component. And like our philosophy is we want to make you comfortable first before we start making dietary change, right? Because dietary change can be hard. And if you're miserable every single month and you feel like you're exhausted all day, trying to make you go on a specific food protocol is the last thing you want to do. So typically we like to do that first. Another couple of questions, and then we'll kind of wrap up. At what point, like at what point should someone start taking medication or consider bioidentical progesterone or permethrin? Like, where do you fall on that? Do you think that's a good idea? Do you think it's a bad idea? I'm just going through all the questions that have come through around endometriosis.
I don't think it's necessary to take medication. So whether it's a birth control pill, painkillers, permethrin, or progesterone, I think. Progesterone and estrogen. Sorry, permethrin is progesterone. I definitely think that is a really good, safe, symptomatic solution for hormonal conditions and perimenopause. But I also know, and I've seen, and we've seen it thousands of times, and I'm not exaggerating, with the results that we get from naturopathic medicine when it comes to hormonal health or endometriosis.
Yeah, yeah. And then if you were just to get started, like what's sort of like the sequence? So what's the first thing you look to help, the second thing, and then you know, what's sort of the process? Like what's step one in giving this a try and seeing, can this help me?
Step number one, I usually go in with the symptoms. So I usually go in with that, with really driving down the inflammatory pathways so that there's pain and inflammation reduction and estrogen detox. Then in terms of correcting, we go into more of a corrective care treatment plan, and that's where we work on recalibrating the microbiome and the immune system. So as you briefly said before, so step number one is a symptomatic support approach. Then we go parallel in with that symptomatic support approach with correcting the underlying cause approach. Yeah. So yeah, inflammation, pain, estrogen, number one. Number two, gut, immune system. And then throughout the whole duration of that is diet.
Awesome. Okay, awesome. So everybody, thank you for coming today. we're going to see how we do if we can keep to this time. It's really hard. I feel like we've missed so much, but we want to try and help. And Tiaan and I have committed to getting one of these out every single week. And so if you have questions, if you want to ask us more things, you can ask us things in the chat box. And in the very near future, we're going to actually set up a whole channel and TV and educational library where you guys can have access to all of our content. So look forward to that very soon. And yeah, if you've got more questions around endometriosis, you think we should talk more about it, ask away in the comments down below. And Tiaan, thanks for doing this with me today. Thanks for making time.
Thank you so much, Carrie. Thanks, guys, and we look forward to more
bye,
videos.
everybody. See you next time. Bye for now.
Bye.
Bye.